I'll try to be very simple and to the point, so that most of the times in the exam, nutrition related questions are not many. But then again, you need to understand and have some basics about how do we feed, what are the different trials somebody can ask, right? Now, the basic question of why do we need to feed, right? For that, even us as healthy individuals, or for that matter, any critical ill patient, why do we need to feed? But again, if you go back to physiology, it is very, to put it in a very simplistic of ways, every cell needs to generate ATP, right? Every cellular function, whether it's a enzymatic function, hormonal function, whatever cellular process is happening, it needs ATP for that function. And if that ATP is not generated, that cell dies. As simple as that. And to produce that ATP, you need substrate. The substrate comes from in the form of carbohydrates, proteins, or amino acids. By and large, it is the carbohydrates, which is the glucose, which is used for all cellular metabolisms. In cases of stress, or in cases where your glucose is not available, then either the lipids or the proteins are broken down, converted to glucose, and in some situations you can have alternate substrates like ketones or fatty acids. So that is the fundamental reason why we need to keep continuously providing the substrates. Because if that process of ATP generation is stopped, then it's a matter of minutes that your entire body will just die. So the body has to continuously keep producing ATP, and that's the reason why we need to feed and we need to give these substrates. Now, if you look at critically ill patients, there are two things which are happening. One is catabolism and one is anabolism. And by and large, all your critically ill patients in the initial stages are in a severe catabolic phase where your proteins are broken down. One of the major difference between fasting and a patient who is in intensive treatment, where again fasting is a process, the major difference is any condition where there is a background inflammatory process going on. Along with fasting, the catabolism is very high and their proteins are broken down. If it's only fasting in a healthy individual, then it is the lipids which are broken down compared to the proteins. So that is the fundamental difference which happens in a critically ill patients, where a large amount of protein is broken down to produce glucose through gluconeogenesis. Now, can we stop this catabolism? The answer is very simple: no. There is no feeding strategy that is available, or there is no strategy that is available which can reverse the catabolism that is happening during the critical ill phase. Right? The only thing we can aim, or the only thing we can hope to achieve, is to try and minimize the damage. So whatever feeding strategies we are going to employ, the idea is if we can minimize this catabolic response and the catabolic damage, then we have done a good job. Now the question is, when do we start feeding? Now, for a long time there was no ambiguity. Whether it's the latest SPEN 23 guidelines, you look at the ASPEN 21 guidelines, the SPEN 19 guidelines, consistently across all the guidelines, almost all the guidelines have recommended that you start feeding early, within the first 24 to 72 hours. 48 hours is the general timeline that is given. So there is no ambiguity with respect to when do we start feeds. Okay, within the first 48 hours, provided your resuscitation process is complete or your patient is hemodynamically stable. Now, even if you have a patient who is hemodynamically unstable and requiring vasopressors, I think we have good enough evidence to say that we can start some amount of enteral nutrition, provided you are consistently able to maintain a minimum mean arterial pressures, your lactates are not going up, and the patient is metabolically stable. So in those situations, you can still start some amount of enteral nutrition. So the question about when to start, there is no doubt, start within the first 48 hours. The problem has always been about how much to give. So that is a problem that I don't think we still have an answer today. There are multiple trials which have been done trying to look at what would be the optimal dosing strategy as far as the nutrition is concerned. Now there are trials which looked at full energy delivery. So whenever we say full or adequate energy delivery, we are talking about delivering 70 to 100% of whatever energy expenditure you have calculated, either by means of a predictive equation or by means of indirect calorimetry. You get a number. If you are able to give 70 to 100% of that number, then that means that you have given adequate nutrition or full nutrition. So the trials have always looked at, should we give full nutrition? Anything more than 100% is overfeeding. So the trials have always looked at, should we give the full energy that has been prescribed versus do we give underfeeding or less feeding, or you slowly start a smaller amount of feeds and you keep going up. Consistently, almost all the trials where full feeding was given either to the enteral route or parenteral route did not show any benefit. On the contrary, whenever you have given full feeding in the early part, especially within the first 3 to 5 days, consistently all the trials have been negative. They've either shown increased mortality, increased infections, more GI complications in terms of feed intolerance or bowel ischemia, or they did not show any difference. So that has given us some clarity to say that early full feeding should not be done. Right now, should we start slow and go up? Again, when you look at trials where they compared full energy delivery with start slow and slow progression, even in those situations, again it was very clearly evident that giving full feeds is bad. So either you give hypocaloric feeds or you start at a lower dosage and keep going up. Right? Please remember the first 3 to 5 days, at least the first 3 days, we are absolutely sure you should not give a full feed because there is what is called as endogenous mobilization of the substrates. The body has certain substrates. The body tries to mobilize those substrates. How much is it? We do not know. So if you are giving full feeds in the first 3 days, then there is always a risk of overfeeding. You are giving external energy and the body is utilizing its own internal energy. The first 3 days, definitely no. Between the 3 to 5 days, you look at what's happening to the trend of the patient and then you gradually increase. So with respect to the dose, please be very sure no full feeding. Hypocaloric, how much will see that? Alright. Definitely, when we say hypocaloric, is less than 70% of whatever energy has been calculated. So if you look at most of the guidelines, they recommend that early nutrition support is needed. However, there is lack of clarity. Now, when we say escalate, we do not know at what point you should increase the dose. Again, we don't know. We say after the first 3 to 5 days, you keep on increasing the dose. We are not even sure about what should be the quantum of increase. How should we increase? All of us have our own way of kind of increasing the feed. Sometimes we say 50 ml, 75 ml, 80 ml. There is no specific formula to say that okay, fine, I'll increase 25% today, 30% tomorrow, 40% tomorrow. What we are very clear is no full feeding for the first 3 to 5 days, then you gradually increase and you try to achieve your 70 to 100% within the 1 week to 10 days period. What we are very clear is we know that if you give full feeding, there is a potential harm, so that we try to avoid. Now, what is the reason why somebody who is getting full feeds has poor outcomes? What is the underlying mechanism? Again, we are not very sure, but the proposed mechanisms are: one is overfeeding. We all know that overfeeding has its own side effects. Then there is something called as inhibition of autophagy. Autophagy is nothing but it's like it's a protective mechanism. No, your body is continuously undergoing metabolism, which creates a lot of cellular debris, and autophagy is a way of clearing all those things because those things are harmful. So if you are giving too much of proteins or too much of energy in the first few days, there is a tendency that this autophagy can be inhibited. So whatever cellular debris is generated is not cleared, and that can be a harmful thing. The other proposed mechanism is probably we are dealing with what is called as refeeding syndrome. So what exactly is refeeding syndrome? What is the pathology? What happens in fasting state is you know that you are not eating, so your external glucose is not there. So after the first 24 to 48 hours of your glycogen stores being utilized, the body tends to shift to fat and protein metabolism, where it breaks it and tries to generate the glucose through gluconeogenesis. Uh, After that, the body tries to decrease its basal metabolic rate. But what happens is periodically the intracellular minerals, trace elements, and vitamins decreases. Now, as a compensatory phenomenon, the kidneys will try to prevent the excretion of this. So, serum levels, if you do serum levels, they may still be normal. But intracellularly, most of your minerals and vitamins are depleted. Now, when you initiate feeding, especially at high doses with a full glucose, you are suddenly shifting from fat and protein metabolism to carbohydrate metabolism. Right now, parallelly, once your glucose increases, your insulin is stimulated, right? Your insulin levels increases, and insulin stimulates your sodium potassium ATPase. Insulin we know is an anabolic hormone, so there is a intracellular synthesis process goes on. So as I've said, these trace elements and minerals are needed for a lot of anabolic responses. So once the intracellular metabolism is stimulated, your phosphates, your magnesium, your potassium moves intracellularly, right? So there is a sudden decrease in your extracellular levels. These transcellular shifts is one of the major reasons for whatever clinical features we see. The other thing that happens is your sodium potassium ATPase also has some anti-natriuretic effect. So insulin also tends to cause sodium retention and subsequently fluid retention. So when you are giving large volume feeds, you are not only causing this transcellular shifts of vital electrolytes, but you are also promoting fluid and water retention. And again, classically, whenever we talk about refeeding syndrome, most of us are always talking about the arrhythmias because of the electrolyte deficiency. But please understand that it is a multi-system phenomenon. It's just not the cardiovascular system where there is arrhythmias, but it can affect practically every system. Your neurological system in the forms of unexplained encephalopathy. You can have hematological manifestations like anemia, thrombocytopenia, muscle weakness. You can have situations where your patient may not be able to wean from the ventilator, and obviously your cardiovascular arrhythmias and pulmonary edema. So if you have a patient where you are unable to explain these conditions, please keep in mind the possibility of a refeeding syndrome. The problem has always been about lack of standard definition. We do not know how to define refeeding syndrome because you cannot. So traditionally, we are always looked at the electrolytes. Whatever trials are there, they always looked at measuring phosphate levels, and whenever the phosphate levels decreased after starting feeding, we assumed it to be refeeding syndrome. So we don't have a standard definition, but there are some recommendations which have been given by the NICE guidelines as well as the ASPEN. These are the risk factors. So based upon your body mass index and how much of your nutritional intake has been the last few days and how much percentage of weight loss has happened, you can categorize them into mild, moderate, and severe. And with respect to your electrolytes, if you have a 20 to 10 to 20% less than your baseline values, you can say that they are at a mild risk. If your electrolyte reduction is 20 to 30%, you say it's a moderate risk. And if the baseline electrolytes are more than 30%, then they are at a very high risk of developing refeeding syndrome. Okay, so for definition purposes, the hypophosphatemia level that has been kind of advocated is any high phosphate levels where it falls by more than 30% of your baseline or more than 0.16 millimoles, you can say that the patient is probably refeeding syndrome. How do you manage? The most important thing is caloric restriction. Now, how much calories to be given? Now, it varies. If you think that your patient is at the highest risk, then start with not more than 5 kilocalories per kg per day. You can gradually increase it over the coming days, maybe 5 to 7 days or over 10 days period. But the starting point should not be more than 5 kilocalories per kg per day. This is for those patients where you think that the risk of refeeding syndrome is the highest. Thiamine is a very important trace element which needs to be corrected or which needs to be replenished, especially when you are feeding patients who have been fasted for a long time. The minimum dose is about 200 to 300 milligrams per day, and preferably you give thiamine at least 30 minutes before because it's one of the important factors in your Krebs cycle in a lot of your glucose metabolic pathways. Monitor your electrolytes very closely. The recommended dose for potassium replacement is at least 1 to 1.5 millimoles per kg per day, magnesium around zero point 0.2 to zero point 0.4, phosphate around zero point 0.3 to zero point 0.6. And as many of these patients have deficiency of vitamins, it is recommended that you also replace the vitamins. Vitamins, 200% of whatever the recommended daily allowance is there, and trace elements is 100% of your recommended daily allowance. Keep a very close watch on sodium, because as I've said, there is a tendency for these patients to retain sodium, and that can also lead to fluid retention. So sodium restriction is something that you have to be very watchful. Fluid balance, be very careful. Very common, there's a practice that if the patient is NPO or if the patient is not getting any nutrition, there's a tendency to just start some IV fluids. If the patient is at a very high risk for refilling syndrome, please avoid doing that, because invariably you are going to cause fluid retention and a very high risk for pulmonary edema. So, let us look at, given the complete set of evidence that we have, what are the things that we should do whenever we're talking about nutrition in a critically ill patients? What are the things that we should do? One, definitely no full feeding. That is something that there is enough evidence to say that if you give full feeding, then you are going to cause harm, right? There is emerging evidence which says that high protein in the early stages, the recent France trial again suggested that again the proposed mechanism is you give too much of protein in the initial stages, there is a tendency to increase your autophagy. So you start again with proteins as well, not only energy, but proteins as well. Start with lower dose and increase it gradually. You obviously monitor for refeeding and overfeeding, and monitor for GA complications. These are 4 things that you should definitely do. What are the other things that I can do? Early enteral nutrition, again, there is no doubt about that. There is good evidence to say that early nutrition is beneficial, but with respect to dose, when you're starting early nutrition, start at a lower dose and individualize. This is a very popular term that is coming up in intensive care. Everything you say at the end of the summary slide says individualize. The problem is nobody knows how to individualize, right? So you individualize depending upon the trajectory of what happens after 3 to 5 days. What we are unsure of as of now, we do not know what is the optimal time point to start, right? We say 48 to 72 hours, but at what point do we actually start feeding? We don't know. Is it 12 hours, 14 hours, 16 hours, 18 hours? We do not know. How do we progress, right? We say start slow. If you look at the latest SPEN 23 guidelines, they don't mention about the calories in terms of numbers. They say start low enteral feeding and then increase. Nobody knows how this progress has to be, right? How to individualize, nobody knows. But then again, there is some vague guidelines depending upon how the patient is metabolically tolerating your feeds, whether the patient is having gastric intolerance, whether the patient is still in the catabolic phase or in the recovery phase, whether the patient is about to be discharged. Maybe those are some things that you can think about to individualize. Thank you.